Başlıyorum. Sayın hocalarım, değerli meslektaşlarım, bugün İstanbul Üniversitesi Onkoloji Enstitüsü Kanser Farkındalık seminerlerinde çok özel bir konuğumuzu ağırlıyoruz. Kendisi uluslararası arenada radyasyon onkolojisinde, özellikle meme radyasyon onkolojisinde liderlik yapan bir isim. Ve son dönemlerde kariyerini lenfödeme ayırdı ve lenfödem kliniğini yönetiyor. Bağlı bulunduğu Harvard Tıp Fakültesi ve Mass General Hastanesi'nde. Bugün de Breast Cancer-Related Lymphedema, A New Solution to an Old Problem başlığındaki konuşmasıyla bizimle olacak. Aynı zamanda bugün İstanbul Üniversitesi Rektörü Sayın Profesör Doktor Bülent Zülfikar da aramızda olacak. Konuşmanın sonunda bağlanacak ve kapanış notlarını dile getirecek. Hi, Dr. Taghian. We are very pleased to welcome you here to our platform today.
Thank you very much, Nergiz. I would like to thank the organizers of this seminar for inviting me, and specifically, I would like to thank you for inviting me. It's a real pleasure to give this talk. And I want to say that Nergiz is a really good friend of mine for many, many years. And I remember very well when she came to Mass General here in Boston and spent several months when she was actually a resident or probably finished her residency, and she came to me and told me, I want to give a talk to your residents. And I was blown away because, wow, I mean, she has really the courage to ask for this. And our audience is very tough. And I told her, that's a tough audience. They will ask tough questions. She told me, I am ready for that. And she gave a talk on a head and neck is right, and this was very inspiring. I mean, I saw an unbelievable self-confidence and a very good preparation, and I knew right away that there is a future leader in the field right here. So I'm very pleased to see Nergiz, and I would like to just talk about lymphedema, which is something I came really to it very much.
Dr. Taghian, thank you very much for your kind words, and it's an honor to hear this from you, and it's very kind of you that you share them today. If you let me, can I also share your brief CV before we start? Thank you very much. Ben öncelikle özellikle Dr. Taghian'ın özgeçmişini paylaşmak istedim. Çünkü onun uluslararası bir akademik kariyeri var ve açıkçası benim kendi bakış açımla o bugünkü farklı perspektifini hem radyasyon onkolojisindeki hem de kanser bakımındaki farklı perspektifinin de çok etkisi olduğunu düşünüyorum bu akademik yolculuğunun. I'm just saying that you have a truly international academic journey, and in my opinion, significantly enriched his unique perspective on both radiation oncology and cancer care. So actually, it's very important for me to note your curriculum. Dr. Taghian is a professor of radiation oncology at Harvard Medical School, received his medical degree from Alexandria University in Egypt. He completed his residency in radiation oncology France, followed by clinical and research fellowships in WC. Dr. Taghian şu anda Harvard Tıp Fakültesi'nde profesör olarak çalışıyor. Ama tıp eğitimini Alexandria Üniversitesi'nde tamamladı ve sonrasında akademik yolculuğuna Fransa'da devam etti. Hem asistanlık dönemini hem de fellowship programlarını WC'de tamamladı. Daha sonra Paris Üniversitesi'nden PhD'sini aldı ve sonrasında da kariyerine Mass General Hastanesi'nde devam etti. He later earned a PhD in radiobiology from Paris and subsequently joined the Department of Radiation Oncology at Mass General Hospital, where he currently serves as the Director of the Lymphedema Research Program and Co-Director of Breast Cancer Research Program. Uluslararası tanınırlığı olan bir uzmandır. Özellikle de akselere parsiyel meme ışınlamasında önemli. 250'yi aşkın makalesi, kitap chapter'ı ve genel review yazıları var ve 2 tane kitabında editörlüğünü yaptı. Bence bu çok çarpıcı. NIH için araştırma grantlerinden 2,7 milyon dolarlık bir fonu özellikle meme kanserine bağlı lenfödema için alabildi. Dr. Taghian is an internationally renowned expert in breast radiation oncology, particularly in accelerated partial breast irradiation. He has authored over 250 peer-reviewed publications, book chapters, and general reviews, and has edited 2 books. He also been the recipient of several NIH research grants, which I think should be emphasized because it's this kind of totaling approximately 2.7 million focused on breast cancer related lymphedema. Ve biz çok onur duyuyoruz ki Dr. Taghian aynı zamanda enstitümüzün uluslararası danışma kurulunun üyesi. We are also very proud to note that Dr. Taghian also serves on the International Advisory Board of the International University Oncology Institute. Thank you very much, Dr. Taghian. You have the floor.
All right, thank you very much. Can I share the screen and start?
Yes, please.
Okay. All right, so I'm going to talk about breast cancer related lymphedema. So if you want to know what lymphedema does to patients, because I personally was not aware, all what we need to do is to ask the patient who developed lymphedema. And we've done this study a few years ago. It's called the Army of Women, 970 patients. And then I will pick some of the comments that came. One person said, lymphedema almost happened immediately after surgery. It has ruined my life. I would almost rather I had died. And this was a little shocking, but the thing which shocked me even more, I fear lymphedema more than recurrence. So she would rather have a local recurrence than having lymphedema. Another person, she's one of my patients, lymphedema became a part of our lives. So that the husband is talking. It strangled the mobility and quality of life from my wife and consequently from me. So when there is a lymphedema, it impacts the whole family. And I don't know if you watch American movies. This is a very famous actress and got an Oscar for a few movies. She came public. She had BRCA mutation, had bilateral mastectomy, and then wrote in public, lymphedema was almost worse than having my breast removed. I was bitter. I was depressed. I thought my career was over. I just want to make the point that the impact of lymphedema on patients is tremendous. So why is that? We can always, we providers, think that, hey, there are a lot of complications of treatment. We have chemotherapy causing all these complications. We have radiation causing all this, and surgery causing all that. We don't really, so it's yet another complication. This one stands on its own. It's different because you could hide all those complications. Alopecia, you put a wig. You have some neuropathy, you just don't talk about it. But having an arm swollen like that is a declaration from the patient to the whole world. I had cancer and I still suffer from the consequences, even 10 or 20 years later. So the mental and emotional healing that we want women to have after this really a big experience in their life becomes very challenging. It is difficult to forget. It is difficult to turn the page when you have an arm swollen, incurable, and you just live with it. And the problem is that it's not only symptoms, limited range of motion, heaviness, pain, and this whole list of symptoms, it's also mental, sadness, anger, depression, and anxiety. It's a lot of things for an incurable situation. So that's the problem of lymphedema, and that's why I think it's very important to get to the bottom of this. How can we reduce this risk? And the problem that we had for a long time is that we always used an impairment-based model, which means that let's wait until the problem happens. Let's see the lymphedema and the swelling there, and then all what we can do, refer to physical therapy, and then you move on with your life as a healthcare provider. Well, this system does not work because it's too late when you do that. When you see the swelling, it's basically too late. What I wanted to do and to have a sort of like a change in the field is to switch this impairment-based model into a screening-based model, into a prevention-based model. And I wanted we oncologists, the surgeon, the radiation oncologist, medical oncologist, like the healthcare provider or the nurses, to be heavily involved in that and not just like to let it go and just send the patient to PT when it is too late. So the question that I asked from the beginning, why progress in lymphedema research has been slow? And then we could say lack of funding and stuff like that, but the way how we were thinking about it was a main reason. And let me tell you why. And this comes from this paper. It's a general review or meta-analysis, like done by MD Anderson. So here the authors collected the best studies in the literature on lymphedema, like the creme de la creme, 21 prospective study. Half of them are randomized clinical trials. You have prospective cohort, like the best studies, and totaling almost 14,000 patients from this date to that date. So what did we find in this general review? We found the problem. The problem is that we don't have a universal agreement on even measuring the lymphedema or defining what is lymphedema. 7 papers had subjective method of measuring. It's not really objective. Like you ask the patient, oh, I have a little bit of swelling. I had a little bit of heaviness. And you diagnose lymphedema. Arm circumference, and I will show you why arm circumference is not a good measurement. Some of those papers did not even report how they measured lymphedema. Then you have other ways, like 6, 7 different methods. They don't connect, and we studied that. And the worst of this, what is the definition of lymphedema? How do you define it? Some people will define it as 2 centimeter tape circumference, difference between right and left. And some papers did not even report it at all. Some self-reported MD assessment. So what we have in this literature is that we are a bunch of people sitting in the same room, and each person is speaking a different language. So there is no communication. We don't understand each other. How can we work together when we don't even agree about how do you define lymphedema? What is the endpoint? How do you define it? And this was the problem. So let's go down to basics. If we start from the basics, I think we can really push the field forward. What is the optimal technique to measure lymphedema? Let's just like start here. And there are many ways of measuring lymphedema. I divide them into volumetric, and you have many ways of getting the volume of the arm. And there is this bioimpedance that I will not really elaborate on it. It reflects the ability of an electrical current to pass through the limb. And it gives you some sort of like a number. It's called LDAX. But volumetric is the main way of measuring lymphedema. So how do we do that? Sometimes you use the tape. So this is the cheapest way to do that. In some places, they take circumference every 4 centimeters here. And then you put the data in a truncated cone equation, and it transforms it into a volume. So that's how it's being done. So we did some studies. Having a circumference every 4 centimeters might take a long time. There is no time, basically. People don't want to waste time. So you could only have 5 points here, and then you will have the same, actually, the same volume when you calculate it. So this is the cheapest way, and it doesn't take too much. Now, a little bit more technology, and that's what we are using in our hospital. It's called pyrometer. It's basically, it uses an infrared volumeter, and you have this frame going back and forth, and the volume of the arm shows up on your screen. So this is maybe a little bit more accurate. But the problem here is it is expensive. You know, it costs $30,000. It's from Germany, and it needs a space. It's a heavy tool, and you need the patient to come to the room. But some people invented this, and we are testing it. It's a 3D camera, and it's like an iPad, and then just like you move the camera around the arm, and it shows the volume in front of you. And we are testing this. It's actually very reliable, and it is much cheaper, like $2,000 or something like that, and you could go to where the patient like. So this is the thing probably of the future. So volumetric, and that's so the most important thing, volumetric, and you calculate that. Now the second question is it necessary to have a baseline measurement? And it just came to my mind that I think we should, but we didn't have information about that. So we looked at our data on 1,000 patients, and we had 35,000 measurements. And we looked at the distribution, the difference between the right arm and the left arm at baseline. So at baseline is before surgery, before radiation, before everything. We just have a patient with a diagnosis of breast cancer from a core biopsy. And we found, to our surprise, we found that 3% of the patient had an asymmetry of more than 10%, which means that we define lymphedema as 10% difference between right and left, between the IPSI and the contralateral arm. So if you don't have this information, you will under or overdiagnose patients. I mean, this information should be known before even we get the treatment. We found 28% of our patients, 28% had an asymmetry of more than 5%. Actually, the European define lymphedema as 5%. If you don't have this information, you will not be able to have an accurate assessment of the swelling in your arm. So then we moved into the following question. What if we miss the measurements upfront? And that's why the role of the breast surgeon is very crucial. The breast surgeon should think about the lymphedema. And the only thing that they can help is that to have an arm measurement before. But I assume that we missed that. And we looked at our data and we made the calculation. We assume that we missed the baseline and we did the baseline immediately after surgery. And then we did it and delayed beyond 3 months, assuming that maybe after surgery, a little bit of swelling happened in the arm, which is very physiological. And we found that if you miss your baseline, you will underdiagnose or overdiagnose 40 to 57% of the patient. And this is a big flaw. So missing the baseline will cause a problem that you might label a patient, you have lymphedema, you need to go to PT, and she doesn't, because her arm was swollen, was asymmetric before any treatment. And therefore, lack of a baseline results in significant misdiagnosis, and this is very crucial. And early post-op measures are not accurate as a pseudo baseline, and that's important. We were not the only people who found that. This is a very big group in England, and they had a trial. Actually, they included 1,100 patients, and they found at baseline, 8% of the patient had arm volume more than 200 ml. And 200 ml is a definition of lymphedema. Actually, baseline, 8% of the patient, they collected some surveys, had symptoms of swelling and or heaviness. The patient reported heaviness in her arm before even starting treatment. So baseline is very crucial. Third question, how do we quantify lymphedema? So we basically generated an equation, and this equation is being used now by a lot of people. It's called a relative volume change. So it integrates the baseline every time you calculate when you measure your patient in follow-up. And it looks a little bit sophisticated, but it is not. A means affected arm, the ipsilateral arm. U means unaffected arm, that's the contralateral. 1 means the baseline, and 2 means the measurements of the day. And you put it in the equation, you just code it, and then it gives you a relative volume change in percentage. So when we say a relative volume change of 10%, this means the ipsilateral arm got swollen with the volume like a 10% increase in volume compared to the other side. We generated another equation for the bilateral breast cancer. Now, the following question, how do we define lymphedema? And here comes the big problem. So there are many definitions in the literature. There is no universal standard definition. You have definition with absolute, absolute, absolute. So absolute volume change, 200 ml, absolute volume difference, 10%. Or the most common one, and I remember all these years when I was resident many years ago, it was always 2 centimeters. And you just like circumference here, circumference there, 2 centimeters more, you have lymphedema. And that's what was done. We are completely against that. And we prefer a relative volume change. And you could define it 10%. Some people will have it 5%. So why is that? We actually found in this big meta-analysis, 7 studies use the absolute difference. Why this absolute difference is not good? I want you to think about it for a second. You have this arm here, right? It was 1200 cc. If you add the 200 ml here to develop lymphedema, you are already 16% increase in volume. That's too advanced lymphedema. That's probably incurable at this time. So we have to wait until the 16%, so we underdiagnosed her. Now take this large arm, which had 6,000 ml as the volume. You add the 200 ml, sort of like lymphedema diagnosis, it's only 3%, which is not really lymphedema at all. So you will diagnose this patient with lymphedema when she had only 3% increase in volume. This is overdiagnosis. How many thousand and thousand of patients, when we use the 200 ml or we use the circumference of 2 centimeters, we were misdiagnosing them. And I asked my mathematician who discussed this with him, Merrick, and I told him we need to put this in graphs in a more scientific way. And you could see that this just increase in 200 ml, which is the diagnosis of lymphedema at that time, represented many, many different relative volume change based on the baseline arm measurements. So what we need to do is not to have a method which will be dependent on the patient BMI or the patient arm volume. It has to be independent of that. And that's why absolute difference between both arms is flatly wrong and misdiagnosis. And we could see this being used in a very important study. Many of us know what is the Z11 study, which is a study which changed the whole paradigm in many things. The Z11 is a surgical approach to the axilla. And when you do a sentinel node, if it is positive in 1 or 2 positive sentinel node, you just don't complete into the lymph node dissection like it used to be at that time. And they looked at lymphedema as an endpoint and compare, this was a randomization, compare the patient who had sentinel lymph node only versus sentinel lymph node followed by lymph node dissection. And they use self-report. And I will show you why self-report is not good. And they use 2 centimeter difference. And the irony is that they show that there was no significant difference in what they defined lymphedema between sentinel lymph node and lymph node dissection. Nobody else showed that. There is no way on earth that this data is correct. And actually, they collected the information by that, but they used a very bad definition for lymphedema. And I have many randomized trials which use really the wrong information. Now we come to another definition. How do you define or how do you diagnose lymphedema? The subjective. So, and we had this in 7 different studies in this meta-analysis. Let me tell you why subjective is not really good. We studied that. And every time we had a patient that we measured objectively and we calculated the relative volume change, we had the patient to fill up a survey to tell us her symptoms. And we put 11 or 12 different symptoms here, from swelling, firmness, the ring is tight, the tighter sleeve, etc. We collected the data and we followed the patient for 5 years. So we have all this data. So what did we find? We found that patient reported symptoms at all level of objective edema, which means that women who had less than 3% relative volume change, which is really within the confidence interval, which means there is no way this is not objective lymphedema, a lot of them complained with symptoms. If it was 10%, 5 to 10%, complain with symptoms, 10% or more. So everybody complained with symptoms. And the other thing, the patient reported the symptoms up till 7 years. So look here, a lot of people still reporting some symptoms. So you don't define lymphedema with just symptoms, because there are a lot of confusion. Some symptoms might not be related to lymphedema, might be related to the scar, to the lymph node surgery. So this is not a reliable definition. So when we established our program, we put some rules. We will use volumetric method. We will need a baseline measurements. We will use a relative volume change. We define lymphedema as 10%, and we could integrate the symptoms with it. And in order to have a successful program, you need a teamwork. You need the surgeon with you. You need radiation oncologist, the physical therapist, a research assistant. That's the way how it's being done. And the whole philosophy for us is, instead of waiting until the arm is that big and say, hey, this patient has lymphedema, we might catch it a little early, and you could see a little bit of swelling here, but we want to catch it that early. You don't see the swelling with your own eyes, but this woman has 7% relative volume change. So we switch from impairment-based into screening and early detection. And actually, based on this, a lot of organizations recommended the screening. The NCCN guidelines is very powerful in the US, and the American Society of Breast Surgeons, the National Lymphedema Network, the people started to think that we need to catch those things early. Some people will tell you it costs more. You will have somebody who will see the patient, who will take the measurements, but there are many a cost-effective analysis. One of us is ours, but in all of them, that the cost of screening is much less than the cost of treating a patient, because the patient will have a lot of treatment, sleeves, and then massage, and then infection coming, cellulitis, or hospitalization, that preventing all this will cost much less. So we started this many years ago, and we generated a database of more than 7,600 patients, and we started to try to learn what are the lessons. And we looked at, okay, what are basically the factors which increase the risk of lymphedema. We identified 6 of them, and some factors to reduce the risk of lymphedema. So let's take each factor. Number 1 factor in the risk of lymphedema is axillary lymph node dissection. And this is one of our studies on 1,800 patients, and all our studies, they have the same style. It's prospective. It has follow-up parameter every 6 months. It has a relative volume change calculated, and we defined lymphedema as a 10% or more. And you could see that lymph node dissection, when compared to sentinel node, lymph node dissection is 25 to 30%. Sentinel node is 8 to 11%. So there is no doubt that reducing lymph node dissection will reduce the risk of lymphedema. But the other thing is that pay attention that sentinel node does not mean that you have zero risk of lymphedema. We have seen patients developing lymphedema from sentinel node. And this is also found in many other studies. So what's the number 2? The number 2 is radiation. And it is very important to understand a couple of things. One of them is not just radiation. You will see a lot of regional radiation, they lump everything together. And this is wrong. So if you see a paper like that, it's flawed. Why is that? We looked at this in 1,500 of our patients, and we found that only regional lymph node radiation increased the risk of lymphedema. If you have breast or chest wall only, the risk of lymphedema is not increased. So you cannot check the box as any radiation. It has to be the patient who received regional lymph node radiation. And that's very important in a multivariate analysis, adjusting for all the other factors. That's number one. Number two, I asked the question, okay, what is the contribution of surgery vis-a-vis radiation? How much surgery can cause and how much radiation can add to it? And we looked at the same study. We divided the patients into 4 groups: lymph node dissection alone, lymph node dissection plus regional lymph node radiation, and sentinel lymph node alone, or sentinel lymph node plus regional lymph node radiation, like applying the AMARO study, and I will come into it. And we found that if you calculate the risk of lymphedema in patients who had lymph node dissection alone without radiation, the risk is 25%. With measurements prospective, with baseline, 25%. You add radiation, it adds only 5%. And it brought a hazard ratio of 1.2. So there is a risk radiation bring. It was not significant, but it doesn't matter here. If you put 10,000 patients, you will have it significant. But what I'm saying is that the main reason is lymph node dissection radiation will add only 5%. If you look at the sentinel lymph node alone, it's 8%, and you add radiation, it's 11%. So radiation add only 3%. And again, it was not significant, but it is a higher risk. So that is very important, because the perception in the literature that radiation cause lymphedema, it adds a small risk. The main reason is lymph node dissection. And here people still started to look at some fractionation. What's the difference between the standard fractionation versus hypofractionation? And this is a study from a randomized trial from China, and they found that there is no significant difference whether you do hypofractionation or standard fractionation, but they define lymphedema clinical. So I'm not really excited about the definition here. There is a randomized trial in progress. It's called REAL from Canada, which compares the hypofractionation 40 gray and 15 versus the 1 week treatment. And they are looking now correct with the relative volume change with baseline and defining lymphedema correctly. This is in progress. And we are looking at in proton, whether there's a difference between photon and proton. This is something we are conducting. I think that there will be no difference because radiation it has a tiny window. It's only 5% contribution. Whether you do hypofractionation, ultra hypofractionation, or standard fractionation, I don't think that you will find any difference, but we'll see well what the data will show. Now, it is very important to know when does lymphedema happen. And it's very important to tell the patient, when you tell them lymphedema is a risk, it is a perception of the patient that it happened during radiation. It actually does not happen during radiation. This is 2,000 patients from our database with a median follow-up of 4 years. Look here, if the patient had lymph node dissection, the risk of lymphedema will go up at 6 months. And then the risk will go higher. And from 18 to 30 months, when you add regional lymph node radiation, and then the risk will go down at 5 years. So which means that once you go beyond the 3 years and there is no lymphedema, you could say that maybe we are all right. And the risk is really low. And I want you to be really very careful. What I'm presenting here, that the risk of lymphedema from the treatment, from surgery, from the adding radiation, will go down after 5 years if it doesn't happen here. But we have seen women developing lymphedema 10 and 15 years later. But my observation is that those women who developed it later, there is some trigger to it. I've seen a patient who had an implant explosion or leaking. They had to remove it, and then she developed lymphedema after that. But she had lymph node dissection 20 years before. I have seen patients who had trauma. And cellulitis is very important. So we have to tell patients, yes, you are a little bit out of the woods from the treatment as a factor, but you are not completely out of the woods. You have to be careful for any cut. If you have a trauma, if you have a fracture, the surgeon should be aware that any intervention can trigger lymphedema. The patient should have probably prophylactic sleeve. What about the BMI? The BMI is universally known to be a risk for lymphedema. And here is from our data, and other people found the same thing. BMI more than 30 compared to less than 30 or less than 25, there is always a significant significance to it, and adjusting for all the other factor. Now comes the question, what if I started with a high BMI and I start to go on a diet and to lose weight? Will this improve or decrease the risk of lymphedema? Unfortunately, no. The BMI at presentation is the main risk of lymphedema, and whether you lose weight or you gain weight, the risk will still there. Other group, really important group, Schmidt's, they found the same thing. The fluctuation of the weight will not change your risk. Some people started to talk about chemotherapy, started to talk about the taxanes, that the taxane increase the risk of lymphedema. So we looked at this in our database. And the literature is really blurry, is not well defined. Some papers showed a significant association of chemotherapy and lymphedema, and others show that there is no significant association. And the idea from taxane that there is some fluid retention, which can trigger lymphedema. We looked at 1,700 patients, and we had this comparison, non-taxanes-based chemotherapy versus taxane-based chemotherapy versus no chemotherapy alone. No chemotherapy, we did not find any significant difference that chemotherapy increased the risk of lymphedema. Now, what about cellulitis and seroma? We found that both are a risk of lymphedema. You've got to be careful. Cellulitis is very bad. And if a patient had lymph node dissection 10 years ago, and for some reason he developed cellulitis in her arm or on her breast, I have seen the arm really blow up. And this is very important to tell the patient. And we found in our data that when the BMI, the lymph node dissection, the regional lymph node radiation became here significant, cellulitis was highly significant in triggering lymphedema. We saw also that trauma can trigger lymphedema. The seroma, we didn't study it, but my sense that the few patients who developed lymphedema after sentinel node, I just realized that they had seroma in the axilla. And for our friends from surgery, seroma in the axilla after sentinel node could be a risk factor to develop lymphedema. What about subclinical lymphedema? Subclinical means we just can't see it with the naked eye. And this term comes only after screening, because you have to screen to detect it, because you will not identify it with your eye. So we defined subclinical lymphedema that this is a lymphedema which is increased in arm volume from baseline that does not qualify as clinical lymphedema. And clinical lymphedema means visible on clinical exam. So we define it as a relative volume change of 5 to less than 10%. And we thought that, hey, if we screen, we identify the swelling between 5 and 10%, let's just intervene here with the sleeve to prevent the progression. So we looked at our database, almost 800 patients, 25% developed the subclinical lymphedema, like the 5 to 10% relative volume change. So we subdivided into the lymph node dissection and the sentinel node. We found in the lymph node dissection, 40% developed subclinical lymphedema, which means that's the 5 to 10%. But we watched them. We did not intervene because we did not have a clinical trial at that time. We watched them. We intervened only at 10%. We found that 60% of those regressed, and only 40% of those progressed into full-blown lymphedema. which means that if we intervene at this point, we might be overtreating some patients. But maybe this is the right way to do it, but we might also decrease this 40%, which progressed into into relative volume change of 10%. When we looked at sentinel lymph node, 25% developed a subclinical lymphedema, but only 11% progressed. So, there is a difference between subclinical lymphedema coming from sentinel node or from lymph node dissection. Now, how can we reduce the risk of lymphedema? If we want to reduce the risk of lymphedema, reduce the lymph node dissection, period. Because the lymph node dissection is the main reason of lymphedema. So when you look at the AMAROS, and the AMAROS is very crucial because it really contributed to the decreased risk of lymphedema. So the AMAROS study is a study which takes patients with a clinically negative axilla, and they do a sentinel lymph node. If the sentinel lymph node is positive, 1 or 2, they randomize between radiation versus lymph node dissection. And that's what they did. And they had maybe 13 or 1,400 patients. And they looked at lymphedema. Now, I'm not also crazy about their methodology, but they did a methodology. It's probably acceptable at that time. And they found that the risk of lymphedema from lymph node dissection was 25%, went down to 11% when you have positive sentinel node plus regional lymph node radiation. And the great majority of node positive patients, they have 1 or 2 positive lymph nodes. So you really saved a patient from lymphedema, like a large number of patients. And we looked also at the same thing in the same study I just presented. And we looked at axillary recurrence was the same, whether you do lymph node dissection or you do sentinel node, positive sentinel node plus regional lymph node radiation. And we switch. We do not do lymph node dissection. Actually, really, we do it rarely. So that's improve the risk of lymphedema. Now, how do we prevent lymphedema? Is there any way to prevent it? So I'm going to talk quickly about conservative approach and surgical approach. The conservative approach is a randomized study which came from India. And they took all women who had lymph node dissection. And they randomized them between prophylactic sleeve, put sleeve right away after the lymph node dissection, versus the standard like weight. And they did really a very good assessment, relative volume change. And they did also the bioimpedance. But the issue here is that they told the patient who were randomized to sleeve, they will need to put the sleeve during all their treatment plus 3 months. So if a woman needed chemotherapy for 3 to 6 months, then radiation, then another extra 3 months. So a lot of patients had the sleeve for almost 9 months. And some patients who did not have any chemotherapy or anything, they will have the sleeve of 3 months. So the length of putting the sleeve was different from one patient to the other. The other problem I have with this study, although the idea is really very good, so they did very nice measurements and they stopped at 1 year. I showed you that 1 year is not enough. You need 3 years to have really a good complete data, but they stopped at 1 year. And they found by using the parameter, the relative volume change, that patients who were randomized to sleeves had 14% lymphedema, and the patients who were not randomized to sleeve had 25% lymphedema. And the same patients were measured with bioimpedance. You could see they don't really match, and bioimpedance exaggerated it, but that's not no time to talk about the bioimpedance now. But this was significant. But this is only 1 year. This is only 1 year. And there is lack of adherence data. You don't know when you prescribe a sleeve to a patient, whether the patient will be using it. And we are trying to work with MIT here to have a sensor in the sleeve to make sure how long the patient used the sleeve. So this was the conservative approach as prevention. Now, what about the surgical approach? The surgical approach is mostly 2 types of surgery. The third one is maybe a little bit less known. The first one is called axillary reverse mapping, and that the breast surgeon can do that. And what they do is it differentiates the lymph node and lymphatic drainage between the breast and the arm. So you inject your dye here, you will identify the sentinel node for the breast, and you take it out. And you inject the dye down here, in upper arm, and you will identify sort of like the sentinel node for the lymphatic drainage of the arm. You keep it, you don't take it out. And so that's what happened. But sometimes you have the same sentinel node for the tumor, for the breast and the arm. In this situation, you have to take it out. It happens in 0 to 20% of the time based on the study. And usually you do sort of like an anastomosis or something like that. There is a randomized trial, Klimberg et al., already completed, not analyzed yet. So we don't know if this arm axillary reverse mapping will decrease the risk of lymphedema. Now the lympha, which became very much a fashion here in the US, a lot of people that just do lympha. So lympha is a microvascular lymphovenous anastomosis. So basically when the breast surgeon, and it needs actually a microsurgical plastic surgeon. So it needs another surgeon to come. Some breast surgeon can have this training and stuff like that, and it adds 1 to 2 hours. So what happens is that they identify the severed lymphatics after the lymph node dissection. So they inject maybe ICG, and then they look at the lymphatics which were severed, and then they take them 1 or 2 or 3 and anastomose them to a branch of the axillary vein. And that's the anastomosis. Will this reduce the risk of lymphedema? So that is the question. But one of the problems here that a lot of time you don't find a branch of the axillary vein, and the lympha is aborted. And Memorial Sloan Kettering has a randomized trial, lympha versus no lympha. And they found as a preliminary analysis on 140 patients in each arm that the risk of lymphedema goes down from 32% to 10%. And there is meta-analysis that the risk of lymphedema goes down. So it's not 100% yet, and still some patients will have lymphedema, that's 10%, and we don't have long-term that. We have only 2 years or something like that. The third thing is something called simplified lympha. And it just like you don't do the microsurgery, you just identify the severed, the transected blue lymphatic channels, and you dissect it and invaginate like using a sleeve technique. And a lot of breast surgeon can do that. Also, there is no randomized trial, no prospective study, but it is like the retrospective study suggests that the risk of lymphedema goes down. So in conclusion, how can we reduce the risk of breast cancer lymphedema? Screening, get it early. If you get it early, there's a good chance that you will prevent the full-blown lymphedema. Identify the risk factor. Keep a close eye on the lymph node dissection and high BMI. That's very important. Both of them is a bad combination. Early volume swelling, cellulitis, all those things are important. You have to counsel the patient, keep a close eye observation. Avoid lymph node dissection. So sentinel node in breast cancer really was a huge, huge contributor to decreasing the rate of lymphedema we see, because the majority of patients have basically negative lymph node. Then the Amaros is a very good step forward. So patients who had 1 to 2 positive lymph nodes. Now in Europe, in Switzerland, there is a randomized trial. Patients who have more than 2 lymph nodes, 3 or 4 or 5 positive lymph nodes, they randomize between a good lymph node dissection versus picking those lymph nodes and cleaning a little, but not severing all these lymphatics. It's called targeted axillary surgery. And if this randomized, it's called TAXES, this trial, if this will be positive trial, like if in fact that having multiple positive lymph node, you don't need to do the extensive lymph node dissection. Just pick up those lymph nodes and give radiation. This will reduce the risk of lymphedema really so much, and we might not really see it. Possible use of prophylactic sleeves or preventative surgery. So I look at this as the future direction. Our goal is to reduce the risk of lymphedema in patients with lymph node dissection from 30% to 10%, and even less than that. So we have 4 defensive lines. First one is replace the lymph node dissection. Don't do it by for sentinel lymph node positive by regional lymph node radiation, and there are 2 studies already showing that you could do that, and possible the targeted auxiliary sampling or the sort of like AMARO study for N2 disease. And this could be, we don't know the data yet. So that's the first time. If you don't do that, you could do a preventive surgery, the lympha arm or simplified lympha, or conservative sleeve as a prophylactic. That's the second defense time. Okay, you missed this one too. You do surveillance, you do screening, and you treat once you see a little bit of swelling, like the early intervention in subclinical swelling. That's the third defensive line. All right, you missed this one too. And you have this last one. Screen. And once you hit the 10%, that's lymphedema, intervene at that time. And I would like to thank you, and also would like to acknowledge my team. I had like maybe 25, 30 people over the years who really generated all this information that I presented.
Thank you very much, Dr. Taghian. As always, this was a great talk with perspective widening opinions and points. First, we have a couple of questions, but first, my personal interest, since I have the floor, I would like to use my advantage to ask this question. Actually, it's very uncommon that a radiation oncologist is now focusing his practice on lymphedema. Observership is survivorship is really important, and it's actually a very highly impactful part of cancer care. But this is actually a rather new concept, and it's very obvious that you have seen this years ago. And what was your, first aim to change your practice to lymphedema? Well, let's say to prioritize lymphedema in your practice.
Yeah, so you mean in my research?
Yeah.
So I would tell you, and I always tell my residents, like innovation is inspired by patients. The reason why I did that is just one patient who I treated, and she had like mastectomy in one side, reconstruction, then mastectomy in the other side. She got radiation, she got chemo, she got recurrence, then metastasis, then chemo. It's like really one of those situations, like it's like you spend years and years just in and out the hospital. And then I was just like walking, and I saw her in the cafeteria, so I sat down with her. And I started to talk to her, and she told me, I can take all this chemo, I can take all this mastectomy and surgery after surgery and all this radiation, but the thing which really brought me down in everything is these 2 arms, because she developed bilateral lymphedema. And I started to think, I never thought that lymphedema will have such an impact, a deep impact on patients. I thought they will consider it's a complication. I'm alive. I have to be okay. No, it's not. You really bring the patient down very much. And I said, why are we waiting until the arm is like that? How can we get it early? And I started to work with physical therapy, and I was made aware about this machine, the parameter, and we had to bring it in, and then we had to start the whole thing. And that's how I got into lymphedema. And it's fascinating. There is nothing there. There was nothing there. Nowadays, and I'm glad that there is more awareness. I see in the major conferences, there is always a presentation about lymphedema. There's now a lot of work going on with this preventative surgery, and a lot of people are using it. So, and de-escalation surgery in the axis, there is awareness, there is a good direction, it's going in the right direction, that one day, and actually everybody now is noticing that we don't see the big arms anymore. It's like I don't see it. It's like rare. It's not like before. So there has been a progress, but we should get the job finished, and it's not finished yet. But we are close.
Yeah. Yeah, you are really right. Sometimes patients are really inspiring to understand, and kind of maybe we have to talk with them. Maybe that's one of the key points. And some questions from the floor. By the way, we had 80 participants, and I would like to thank them all too for their input. And I will be taking a couple of questions. One is, exercise is a crucial survivorship recommendation after breast cancer treatment. Do you think breast cancer patients, are there any exercises that breast cancer patients shouldn't be doing to avoid lymphedema?
Right. So that's a very good question. I mean, and there is something called precautionary measure that we used to tell the patient. Let me go back. Lymphedema field is full of wrong information and full of wrong instruction. It's really fascinating. For instance, we tell the patient, don't use your arm, because when you use it quickly, you might generate some drain. It's just wrong. It's the opposite. When we tell them don't use the arm, the risk of lymphedema actually increase. And there was a randomized trial to exercise versus not. And the risk of lymphedema went down, and women who had lymphedema, the lymphedema improved. Exercise is very important from the beginning, but with one condition. When you do weight, you have to go slowly, and you increase weight in a very gradual way. So that's one thing. There is still, don't, like when you fly, when you take a flight, you need to put sleep. Wrong. It does nothing. Don't have your blood pressure measured in the ipsilateral arm. Wrong. It does nothing. We have a study that we are submitting on 2,000 patients about the infusion. You keep telling the patient, don't allow any blood drawn, don't allow any infusion from the ipsilateral arm. We studied that and we looked at it. And there is absolutely no evidence whatsoever that any of these guidelines that we used to give the patient completely wrong. And you will notice in the next year or two, because we are sitting on many of those guidelines generating committees, that we are changing all this. And this hurt the patient and not only prevent the lymphedema. No, we are very much pro-exercise, and exercise actually have the feeling that it reduces the risk, but it has to be done in a very gradual way.
So thank you very much. And a second question is there a relationship between type and number of symptoms and lymph volume?
And you mean lymph volume means the lymph node dissection volume?
Probably, I think the size of the lymphedema or the volume of the lymphedema.
Oh, I see that. So what you're saying, so basically I showed that it's like, let me go actually back to this study that we've done. It might here. So that's the slide here. So those are the symptoms here. So you could see the patient who had more than 10%. So that's a larger volume. We see more red dot. So red dot means a lot of symptoms, more red dots here.
Mhm.
But we also saw a little bit less than red dots, that but 5 to 10%, a little less. So I would say yes, there could be some correlation between the number of symptoms you have and the volume you have. We did not look at this in a direct way, but you could notice it from all these dots that the red dots increase with the increase of the volume. And I hope this answered the question
Yeah,
for.
yeah, probably. And I would say it was a very good catch. Yeah. And I think that's it. Okay. Thank you very much, Dr. Taghian. I think we answered all the questions. It was a great pleasure and honor to have you here today. And as always, this was an inspiring talk. And I'm actually looking forward for our future conferences.
All right, I would be very happy to come back. And thank you very much for inviting me, and great to see you, Nergiz.
Thank you. Thank you so much. Herkese çok teşekkür ederiz, tüm katılımcılarımıza. Seminerlerimiz devam edecek. Umarım aynı tatta ve aynı heyecanla devam edebiliriz. Herkese iyi hafta sonları ve iyi tatiller diliyorum.